was excellent, but most of it concerns cosmetic lengthening. So all this legal thing, notary public, everything is needed if you are making somebody taller. Because he was a normal physiological man, and just like a breast augmentation or no surgery, you are giving a cosmetic Ilizarov surgery. That you charge much, risks are high, rewards are high. But for those who attend this course, I do not think that cosmetic lengthening is the first thing to do. Try it in tibial non-unions, get confidence, then go to difficult things. He showed you humerus, he showed you carpals. So these are all for the expert. You do 100 cases and then start doing them. Don't start offhand and get your fingers burnt. Dr. Ilizarov from, Dr. Mohammad Younus from Allahabad.
Good morning, ladies and gentlemen. Now I'll be talking about the main indication of Ilizarov, that is fractures. So fractures is one of the most common situation where Ilizarov comes in handy, and you can see in this photograph the entire skeleton is covered in Ilizarov apparatus. So it virtually means there is not any bone in the skeleton that cannot be addressed, whose fracture cannot be addressed by Ilizarov methodology, excluding probably the ear ossicles where we can't reach with our wires. So but we'll be very tempted to do Ilizarov surgery soon after you finish your workshop, and when you leave, you will be very tempted to do your Ilizarov surgery. You will be virtually any fracture that you see, you will be tempted to do Ilizarov. So you have to first ask yourself, is this the right indication where I have to do Ilizarov surgery? Can it be better managed by alternative methods? The AO school of thought will look very small in front of the giant Ilizarov. So you have to make sure, can it be better managed by alternate methods? If it is not the case, then be brave, go ahead with Ilizarov. Otherwise, think twice before consulting the patient about this particular option. And pre-operative preparation is very important. This is how routinely it looks like when I am planning for an Ilizarov surgery the day before or a few hours before. All my equipment will be laid out. My assistants will let me know whether there are any special requirements for this particular case. If it is so, we have to procure it. And we have to understand whether we have to follow the purest way, like all wire construct, which the Russians do, or do we have to do the hybrid manner, which the later Italian surgeons modified. So in a proximal femur, whether you need these type of arches or these type of arches, get the things ready so that you are not lost while on the table. And the proximal humerus, these omega rings are specially designed so that you don't face much problem when you are applying an all-wire Ilizarov fixator in a humerus. So keeping all necessary accessories are handy. And you see here in this particular patient, it's otherwise well done Ilizarov. For a proximal, there's a proximal tibial corticotomy, there's a mid-third fracture which has been addressed with Ilizarov. The shortening, lengthening is going to take place at this corticotomy level. The patient is able to weight bear despite the shortening. Foot equinus has been corrected well with a foot frame. But you see here, at this point, there is restriction of knee flexion. The reason is, instead of using a 2/3 ring or a 5/8 ring at the proximal tibia, I have inadvertently, or rather purposefully, I have used a full ring here. So the ring is abutting on the back of the thigh, thereby restricting flexion. This will cost some amount of movement in the long run, thereby inducing some stiffness. This abutment is what should be avoided. Had I used a 5/8 ring, this will not have taken place. I would have got more flexion. Like in this lady, there was a tibia, it was lower third, so I did not have to use a full ring on the proximal tibia. So this 5/8 ring is letting her keep the knee flexion to the fullest. Similarly in distal humerus, if you are using a 5/8 ring on the distal humerus, that will help you a lot in preserving the joint range of motion during the course of treatment. You can see this patient is holding the most heaviest book in my OPD, written by Dr. Prakash himself. Just to show the fact that the functional status during the course of treatment. And having decided which way to approach, the purist manner or the hybrid manner, and what all implants we need, keeping them all ready, then another golden question that has to be answered is whether we have to follow a progressive construct or a prefabricated frame. Then nowadays, I am not biased towards either side. I use a mid-path approach. I partially prefabricate it for the proximal fragment, partially fabricate for a distal fragment, thereby saving a lot of time. At the same time, you have the flexibility of the progressive construct approach. So that mid-path approach is a very right way to go ahead. In progressive construct, this is how you will go inside. You will have all the armamentarium with you. all the arches, rings, wires, everything, the accessories, everything laid out in front of you. And during the course of treatment, the look will be somewhat like this. Wires introduced, fracture getting under reduction because of traction, other manipulative measures, then you mount the assembly. Whereas in prefabricated, you will have to spend some time before surgery, spend some time before the patient is under anesthesia, construct your frame according to your situation, put your hinges, distracting rods, wherever you feel like, use short connecting plates appropriately, so that anesthesia time is reduced. And not much of thinking has to be done on the table when the stress level is high for the surgeon. Then the first step in Ilizarov surgery for a fracture is traction. You can apply it manually, you can apply it by skeletal traction, you can have your own special traction tables, or you can use your regular orthopedic table that we use for femur fractures, DHS or PFN. That boot traction device alone can be used. For tibia, you can use a calcaneal pin traction. For upper limb, you can modify your lower limb traction table by some means. You can add some Ilizarov assemblies into the traction rest so that it gives more traction. This is one modification that I suggest. I use the old Ilizarov ring, put it on to the footrest of the normal fracture table, and hold the ring onto the patient's hand. The ring is held by the patient's hand himself, then it is tied over with bandages, and that alone gives a good amount of traction instead of passing a metacarpal pin. You can apply the traction in flexion, you can apply traction in extension according to your situation, and you can achieve very good reduction. Then the next step, after having provisionally aligned the fragments, there is not much of deformities seen in the limb. There is no gross varus or valgus, no recurvatum or procurvatum. Now comes the step of insertion of wires and half pins, according to whichever school of thought you're following. But one has to make sure that the rings are always perpendicular to the long axis of the bone. Never ever should you consider keeping it perpendicular to the skin surface. Then you will be caught. You will be caught in the wrong foot. So your rings have to be perpendicular to the long axis of the bone and parallel to the adjacent joint surfaces. And then comes the assembly of the frame. Then proper wire insertion according to the tips which I discussed earlier, so that the range of motion is never lost at the end of the surgery. This is how a trauma frame looks like. There is a proximal basic support. There is a distal basic support. Once these two supports are applied, then comes the intermediate supports, which will have reductionally fixing, meaning those wires or pins that are put in the intermediate ones, they not only fix the bone, they also reduce. They serve the purpose of reduction, at the same time fix the fracture at the right anatomical location. This is how a tibial frame looks: a proximal basic support, distal basic support, and an intermediate reductionally fixing support. In tibia, generally the rule is always have rings of the same size. But in certain situations, when the proximal dia is very big and the distal diameter is very small, say the difference is more than 5 to 6 centimeters, you better use rings of different sizes and connect it with short connecting plates and make a more stronger and sturdier frame. And this point, I think, has already been illustrated. When passing a distal tibial wire from anterior to posterior, when entering the anterior cortex, the foot is in dorsiflexion. When exiting the posterior cortex, the foot is in plantar flexion here, and when exiting the posterior cortex, the foot has to go into dorsiflexion. Similarly, when a wire is passed from posterior to anterior, it is the reverse, so that the ankle range of motion is preserved at the end of wire insertion. The same principle applies to hip. When passing wire from anterior to posterior, entry point has to be in flexion, and when posterior to anterior, it has to be in extension. The same thing applies to the knee, so that if you follow all these principles of wire insertion, you create some excess stock of skin at around the joint level, so that after application of the frame, after reducing the fracture, the range of motion of the adjacent joints are completely preserved. See here, in this particular patient, we have used all this. This is a forearm fracture presenting with non-union, managed with closed Ilizarov method. See, at the end of the surgery, the first day functional status is this. This is all because of the wire being introduced in the right manner, and an appropriate skin stock and a soft tissue stock has been held at the joint level. In case the joint is stiff or because of some constraints, you are not able to pull the skin into that place, you better create a hook-like apparatus with Ilizarov accessories only and pull the skin. For example, in this case, probably this patient might need a femur lengthening. So you create some excess stock of skin towards the lengthening zone so that that can be used during the course of lengthening. And I said the wires have to be introduced perpendicular to the long axis of the bone and not perpendicular to the surface of the skin. In certain situations, we get fooled because of the deformation forces acting on the fracture. We might inadvertently introduce a wrong wire. Then, subsequently, when we introduce the reductionally fixing elements, when we achieve anatomical reduction, this wire goes in for deformation. If you retain this wire in that same position, what happens is this wire creates an elastic force that tends to lift the fragment outwards, whereas this olive wire, which is trying to reduce the fracture, they mutually oppose each other, and that will lead to some added elasticity to the frame. Thereby, the stiffness of the frame is reduced. So in such situations, better to revise this wire or use the same wire but fix it at the appropriate level with posts or washers. Then, having achieved provisional reduction with traction, then comes the step of correction of other deformities, namely rotation and translation. How do you achieve translation correction? This was already discussed with short connecting plates appropriately attached. Once we tighten it, the translation corrects automatically. In this particular patient, there was a femur fracture which was managed by Ilizarov. There is a short connecting plate that is pushing this distal assembly towards the proximal assembly, thereby holding the fragment in reduction. This same thing can be achieved gradually with threaded rods. If there is stiffness in between and you have not opened the non-union side, you want to do it gradually, the same thing can be done with threaded rods and the sequentially correction of the translation can be achieved. And coming to rotation, if there are some rotation left at the end of your traction, now how you correct it? The nuts are connected not parallelly. In the adjacent rings, the rods are kept little oblique. These rods are connected to the next adjacent hole, and slowly as you tighten it, it goes in for correction. I'll show you a case here. This is the fracture femur. It was a non-union after having underwent interlocking nailing and subsequent dynamization. You can see here that the distal femur is in external rotation. To confirm, exactly document the amount of external rotation in femur, there is no good X-ray view that will show you the amount of external rotation deformity. So the better method is CT, a proximal femoral CT and a distal femoral CT. Two limited cuts alone will help us clinch the amount of rotation. See here, this entire femur has gone in for external rotation. So for this, after having calculated the amount of external rotation, giving some value for the anti-version, we calculate the exact amount of rotational correction that is needed. And in this patient, the rotational correction that was needed was around 30 to 40 degrees. So here we are using a ring which has some 40 holes, total of 48 holes. And here you see the junction of this ring is at this point, whereas the junction of this ring is at this point. I have migrated 5 holes. Initially the rods were kept oblique, and as we tightened it, the rotational correction takes place. So around 5 holes of correction in a ring which is 48 degree will be close to 37.5 degrees. So we can accurately document the amount of rotational correction that we are bringing forth into the non-union site. You can also achieve rotational correction with wires. If this is the wire you have passed, and if you fix it in the adjacent holes on either side, then we are achieving a few degree of rotational correction. If you want more, you can migrate one more hole on either side. So this is how you achieve rotational correction. Make sure at the end of fixation, the anterior superior iliac spine, the patella and the second toe are on the same level. If they are, then that is the stop of your rotational correction. Then comes the correction of translation deformities. You can, translation deformities can be corrected with wires, with olive wires, with arched wires. There are various methods described. For example, if assume this fragment is lying in this portion and you want it to lie here. So what we do is we can pass an olive wire, and the bead is parked on the cortex of the bone and slowly pulled with a tensioner or with a T-handle or whatever. Slowly pulled till you achieve the right place and you fix it there, then tension it on the other side. Assume in a situation where such a wire is not possible because of some anatomical constraints. Say this is not lying in the safe corridors. What we do is we pass a wire in the safe corridor, whichever position it is feasible, pass a wire, then use it in an arched manner, try to tension it slowly, it lifts up, then after having lifted up, then you create the correction on the mediolateral axis. So you have to accurately document how much of procurvatum, how much of recurvatum, how much of varus, how much of valgus, and appropriately use your olive wires and arched wires to your support. To demonstrate this case, yes? In this case, without? I'm not getting his question. It is actually the deformity that is getting corrected is the translation deformity. So if you look at the limb, it is the deformity happens to be there in only one plane. But in 90-degree axis, there is a varus deformity, there is a recurvatum deformity. So the same olive wire. If you can introduce the wire along the plane of deformity, then one wire is sufficient and one correcting force is sufficient. The olive wire is just pulling and the fragment is falling back into place. But assume this wire is not possible. Say there is posterior tibial artery here and you can't pass the wire here. So what we do is we pass a wire through the safe corridors, hold it in an arch manner and slowly tension it this way and give the necessary pulling force on either side and bring the fragment to the right place. You should not risk injuring a vessel just to achieve this reduction. So according to the local anatomy, you will have to tailor make your reduction concepts. This is a Montague fracture dislocation which presented to us with non-union. So this patient was suggested open reduction by me, plating and bone grafting, but the patient refused, saying, I do not want one more scar in the fracture side. And if it is possible, no scar in the forearm also. So we gave him the option of Ilizarov and he chose it. And here, this was our pencil sketch of the plan, a proximal ulnar basic support, a distal ulnar and a interosseous basic support. Then this is the reduction assembly. In the reduction assembly, you can see I am planning to place, this is an oblique fracture. So I'm planning an olive wire on this direction, another olive wire on this direction, so that the olive alone is giving a translational correction. And thereby some interfragmentary compression too. So this is the patient. You can see the olive is trying to pull on this side, this olive is trying to pull on this side. This non-union side is not open, it is entirely managed closed, capitellar joint. This is the course, during the course of treatment, the patient is fully functional. You can see the flexion range with the X-ray itself. Here we are doing gradual correction since it's a non-union situation. If it was a fresh fracture, all the reduction can be achieved right on the table. But it's a non-union, so we have attached those olive wires to a slotted threaded rod, and this is the pulling assembly on this side, this is the pulling assembly on this side. This is the post-union X-ray. You can see excellent consolidation. There is no need for opening of the non-union side. There is no need for freshening of the bone edges. There is no need for adding bone graft or bone marrow injections. You don't need anything at all. The radial head is beautifully reduced into the radiocapitellar joint. The non-union is no more to be seen. This is the beauty of Ilizarov. So in Ilizarov, always shy away from opening fracture sites. However atrophic the non-union, you can stimulate it. You can reawaken the union process if you are using the magic of Ilizarov appropriately. And you can use also reductionally transfix with half pins. In certain situations, pins will be a guide for reducing. And if you are using pins, you must have such slotted, horizontally slotted female washers, female posts or male posts, so that you can keep moving the pin and fix it at the appropriate point. And how to manage comminuted fragments? You can use olive wire induced compressions like this if it is a big fragment, or if it is a very small fragment, you can use wires that are arched over the surface of the bone. You can also use what are called console wires. Here, the olive wires are just cut at the tip and they are held onto the comminuted fragment and they are slowly reduced. So the amount of reduction force that we achieve with this console wires are very less, but still they are quite worthy enough at certain situations. And intra-articular fractures, they are an excellent indication in Ilizarov. Here we also use another principle apart from the regular Ilizarov here. We use what is called the ligamentotaxis. We apply ligamentotaxis across the joint, achieve some amount of provisional reduction with ligamentotaxis, then use olive wire induced compression, or you can use some hybrid method to achieve compression across the intra-articular fragments. So in distal femur, you apply traction across the knee joint. Then after having achieved good reduction, you can either remove the distal proximal tibial assembly right away on the table, or you can do it at the end of 4 weeks after early union has taken place. Similarly, here in proximal tibia, traction is given across the knee joint, and after achieving anatomical reduction and a proper joint line restoration, you can remove the proximal assembly from the distal femur. If there is depression, always correct the depression, use appropriate rafting, use number of wires to hold the elevated depressed fragment from falling back again, and if you are not happy, you can add some cancellous screws along with it. So you can make it as a hybrid type of fixation. Same thing with the distal tibia. If there is intra-articular comminution, you will have to do a ligamento-taxis along the ankle, and all the fragments will beautifully fall into place. Then all that is left is just a few olive wires to hold the fragments in compression. This is a pylon fracture. This is the preoperative frame that we are using here. And just before surgery, we can just plan what all will be the direction of the olive wires we'll be introducing, and make a mental picture so that we are ready before hand. And here there is the olive wires inducing good compression across the fracture site, and weight bearing status right from the day one of the surgery. In intra-articular distal humerus, that is another beautiful indication for surgery. Having, if you are very confident about the cross-sectional anatomy of the upper limb, nothing can beat Ilizarov in distal humerus. Otherwise, such cases have to be managed by double plating through a olecranon osteotomy with a long union time, with a very dicey situation in the post-operative period, whether the range of motion will be restored or not, all such is there. But if you are managing it with Ilizarov, no incision made, no olecranon osteotomy, all reduction achieved by very few olive wires. Here I have just used 2 olive wires for achieving both medial pillar and lateral pillar compression, and the metaphyseal fracture restoration also. This is the on-table situation. The range of motion is very good. And in distal radius, this is another place where I have learned a lot from Dr. L. Prakash himself. This is how the usual Ilizarov textbooks describe normal distal radius fixations. You apply ligamento-taxis, achieve reduction with olive wires. This is how I was doing in the previous days. But nowadays, I am avoiding this middle ring. Just with 2 rings alone, I am getting good compression. Here, the intra-articular reduction is achieved by distraction between these 2 rings, and after having achieved good reduction, there are 2 olive wires here, bringing some compression at the intra-articular fracture site. This is an excellent restoration of the joint line, and good function result was there. This is Dr. Prakash's own technique of managing maluniting distal radius or Barton fracture dislocation. Here we use a half ring on the metacarpal and a full ring on the mid forearm. You can use hinges to appropriately introduce some radial deviation or volar tilt as per requirement. This is the radiographic appearance of one such case. It's another case managed by this method. Here, the tip is this. If there is a Barton fracture dislocation, the hinges have to be placed appropriately so that you can migrate this half ring either volarwards or dorsalwards. If there is a volar Barton, this hinges has to be reversed. If it's a dorsal Barton, hinges have to be in this manner, so that you achieve compression across the fracture line also with this methodology. And how to manage Ilizarov management of compound fractures. Here we essentially the treatment plan is the same if there is no bone defect. If there is a bone defect, then we'll have to resort to bone transport, corticotomy, etc. And along with that, we'll have to keep in mind that we need to manage a soft tissue also. This is one such patient, a compound fracture tibia managed by external fixator in another center. They tried to make drill holes into the dead bone, try to create granulation into the raw area. Later on, they grafted, the graft failed again. The patient was referred to us. Here, after complete debridement and resection of the bone, we did Ilizarov bone transport. Here, for soft tissue closure, we used Ilizarov. When Ilizarov can make bone, why not it can be used to make soft tissues? Here, we can use hooked wires or olive wires onto the skin edges and slowly migrate them eitherwards, cross them over like this, so that you gradually cover the defect over the bone, and you can achieve coverage of bony defects without any need for flaps or grossly deforming plastic surgeries. So this is the patient that I was discussing about. There is a huge bone exposed defect now. What we do is hooked wires on either side of the skin edges, and they are crossed over. And you see the edges are beautifully closing. No suture can hold such a closure by itself. And there is no provision for gradually closing it with sutures. So you can hold them together till the healing has taken place. And you see such a beautiful scar. There is no flap, no raised, no grotesque deformities. It's all patient's own skin developed from the local milieu. So this is the best thing we can do in such situations. And you can appreciate that the bone transport is happening just underneath this newly formed skin. This will slowly, gradually increase the blood supply of the area also, thereby aiding in the healing. This is the proximal corticotomy. The distraction is happening at a steady rate of 1 mm per day. And as soon as we dock here, this direct bone transport will be converted to a crisscross wires, and a compression across the docking site can be achieved. Thank you. If there are any questions, doubts, I'll be more than glad to answer. Ulna non-union. Acute, no, it was a non-union case. Here I am doing it gradually. You see, those olive wires are connected to us what is called a slotted threaded rod. We'll be introducing those accessories into your workshop shortly. And those slotted threaded rods have a provision of attaching the wire onto the slot of the threaded rod. If you do not have it, you can attach it directly to a male post, or anything will be fine, as long as you are able to pull it. So the slotted threaded rod, once you see it, you will be able to appreciate it. Two nuts will hold the wire into the slot, and they are held together rigidly.
And instead of applying a ring for distraction while fixing a periodical fracture, is there a role for femoral distraction?
Femoral distractor. You can apply femoral distractor to achieve provisional distraction, and later on remove the distractor right on the table. Or if you want, if you feel like I need the joint to be held in distraction for at least 4 to 6 weeks before letting the patient mobilize the limb, you can leave the ring across the joint, leave it like that, let the intra-articular healing take place, let some 4 weeks go pass by, then remove the trans-articular fixation, then start mobilizing. It all depends upon how stable a fixation you have achieved.
While closing the wound, when you use olive wire, is there a chance of
Cut through. Yes, that's a beautiful question, right? Quite frequently by people who have started using this. Those who use it in the appropriate method, it's always a race of time. Any wire is going to cut through. Before that, you have to achieve a closure. That's it. So to decrease the number of amount of cut through, you can increase the number of wires so that it is dissipated across multiple wires. And the wires have to be held in the right tension, just like you are applying bone transport. Each wire is held by a tensed wire. Similarly, a skin wire also has to be tensed appropriately, but we can't